alaikum wa rahmatullah. Sabah al khair. So, hope you're all enjoying your time. I would like to extend my gratitude to the organizing committee and actually congratulate you. You actually exceeded the expectation, so I have to say that before I start. So my talk today is going to be on gout. And it's always a challenge to talk to a group of rheumatologists about gout because, I mean, you guys probably treat gout better than I do. However, there are some things maybe that we're going to reestablish and see how we can go through with it. So I'm going to actually start by the opposite. So I'll just give you my take-home messages, and then we'll walk our way through and try to conclude with the same conclusions. So hyperuricemia is necessary, but they are not sufficient to cause gout. And difficult to control gout doesn't mean resistant disease, and I'm going to show you how. Allopurinol is not nephrotoxic, and appropriate urate-lowering therapy is important because you can remove the deposits, and hence you're going to stop the flares from occurring, hopefully. And treat to target is an achievable goal. It's something that we can do. It's not like a myth. So let's go through with it. So if you know this, you know how to treat gout. Anyone knows how to treat gout. You have hyperuricemia to a certain degree that is exceeding the saturation point, and then after that you'd have some deposition that occurs in the joints or in the soft tissue. Later on, this is going to result in a way into self-resolving flares that usually are recurrent. And then if you use an appropriate anti-inflammatory, you're going to abort the inflammation. Urate-lowering therapy, you're going to stop it from happening in the future. So it seems to be easy, right? Like everyone should know it. Family physician can treat it, internist can treat it. However, for us rheumatologists, I think each of these boxes have like some intellectual and practical interest for us. So let me just go through with it. So when we talk hyperuricemia, we do understand that it majorly happens because of the kidneys. What happens basically is that the renal reabsorption gets high based on this receptor, the urate1 receptor. So everything gets filtered in the kidney and goes out, and then except the uric acid, you get to reabsorb it, except about 10% that goes out with the urine. This is the major way where we're getting the uric acid from. Then the GI excretion. So back in the days, we did not put a lot of weight. Now we understand that it has a bigger proportion than what we thought. So a specific transporter, a polymorphism to a specific transporter can dictate which patients are going to excrete more in the gut and which are not. In a way, it kind of dictates who are going to have hyperuricemia and who are not. This is like a new exciting knowledge for all of us. And then there was multiple GWAS studies that show that there are some enzynopathies that we don't really know. It's not fully explored, but it has like a strong association genetically. Another important factor that we used to think that why women premenopausal don't have gout, right? And then we thought, well, it's easy because they have estrogen. Estrogen is a uricosuric agent, so that's why. Well, it wasn't really true because like estrogen would account only for 0.3 milligram per deciliter, which is supposed not really to be protective. There should be another factors that we still are going to explore and find out. Obesity, obstructive sleep apnea, other part of the metabolic syndrome, all of these things do happen with hyperuricemia, and we tend not to know why they do happen. And then there are some theories that because of these soluble crystals, this is why we're having these other comorbidities. Now, fructose does increase the synthesis of uric acid, and then other agents like alcohol and some drugs also contribute. But all of them, they contribute to a certain degree. It's not like super high. So it does tell us that serum uric acid does predict the likelihood of initial gout. This is like a well-known knowledge for us. And this is an analysis of 4 publicly available cohort. So what they did, they kind of recruited 19,000 participants, like big number. And then they did a uric acid, serum uric acid at the get-go, and then they followed them in the future. And what did they find? What's expected, that if your serum uric acid is low, less than 6 milligram per deciliter, your probability to have gout in the future is less than if your serum uric acid is more than 10 milligram per deciliter. So the survival of you survive like gout-free period goes down. Now what's interesting is that if you look at this highlighted box, so they picked people who had serum uric acid more than 10 milligram per deciliter, more than 15 years, so they have the duration, they have the level. Only 50% out of them, they do have gout, or they develop gout. which is interesting. You'd expect that more than this, they should actually have it. So this tells us that hyperuricemia is necessary, but it's not sufficient to cause gout. Now, the other important factor about the deposition is that crystals. You can find crystals in between attacks. So not always if you find crystals, it means that you are in a gout attack, in an active attack. This tells us that, well, maybe the crystals itself have a problem, like maybe they are coated with a specific protein causing this inflammation, or maybe the individual patient response. And this actually excites the idea of the dynamic inflammatory tone. It's unfortunately out of the scope, but it's like an exciting new knowledge on why crystals not always causing gout. And this also was replicated in the double contour sign by the ultrasound. So you find the deposits, 25% out of the asymptomatic hyperuricemia, they do have the deposits, but that they're not necessarily going to develop gout. And unfortunately, we don't really have an answer on who have a urate deposits are going to develop gout. The old trials of the all urate lowering therapy does suggest that if you're going to reduce the amount of serum uric acid, you're going to reduce or control gout. And then it seems to be that the number 6 or below, kind of the magic number, and it's a scientific fact. However, some people are trying to argue against it, but this is a scientific fact that we have. So managing gout is suboptimal. So a third of the patients who are treated for gout are on appropriate doses of urate lowering therapy, which is really strange because it does seem to be a logical disease. It seems that we're having a target. Like we always complain that, well, on rheumatoid arthritis or psoriatic arthritis, we don't have a target. Now we do have a target, we have a number. So how come we can't reach this? How come it's complicated? Some of the reasons that the diagnosis of the, treating uncontrolled gout is difficult is by diagnosis. You know, we still need synovial fluid. We still need to see crystals. You need to rule out infections. You need to rule out other crystal disease. Now, ultrasound and DICT scan are very interesting and accurate tests, but again, you cannot exclude the other possibilities. Please remember that serum urate is not sufficient, even if the number is high. And then they come up with clinical algorithm where you don't have to take the aspiration all the time. Patients coming at night, there are some small joints, they're refusing to take the synovial fluid, so they come up with different algorithms to do that. So for example, this is a patient, he's a male, hypertensive, he has high serum uric acid, and he presented with one day acute attack, cannot really walk on his feet. If you go through with different algorithms, now this is one of them, it's an example, you actually see that this patient scores about 11, which means that in 87%, based on this algorithm, this patient has gout. Well, maybe not. Actually, in this case, this patient had Staph aureus septic arthritis. So every time when you're dealing with something that doesn't respond well the way you're thinking, please revisit your diagnosis because it could be not. Another important cause for uncontrolled gout is based on the natural history of the disease. Now we understand that it starts kind of mild and then it goes through the way and becomes really advanced and severe and difficult to control. So you keep in your mind which area or which point in time we are treating the gouty patients. Now chronic kidney disease patients, either if they are on hemodialysis or they are going to the ward hemodialysis, they are going to be a challenging population, aren't they? It's a disease, it's a patient population problem. That's why we can't really control them. Now, we know that 20% of our gout patients, they do have chronic kidney disease. Please remember that allopurinol is not nephrotoxic. This is a discussion that you're going to have with nephrologists, at least some of you are going to have with your nephrologist. It's not a nephrotoxic drug. The thing is with allopurinol hypersensitivity that happens more in chronic kidney disease, it's kind of an allergic reaction rather than a toxic buildup, right? So we understand it has a high risk in patient who has chronic kidney disease, and then they suggested that there is a dose reduction. However, there's no science behind that. It's more of a theoretical background that we actually adopted. And there was no hard data. Where does this come from? And even if you go by the ACR and ULR, you can find that there is no consensus on how low we should start and how slow we should go up. But this is what we are going to do anyhow. Now, other possible explanations for why is it difficult to control gout. Maybe it's a suboptimal compliance. Now, it's always easy to blame the patient. Well, they're not compliant, and that's why we cannot really control the disease, right? Or is it the suboptimal dosing? Maybe we don't use enough dosing to reduce the serum urate. So you have actually to titrate it up. Most of the general practitioners, they kind of do it in the beginning and they don't follow it up. They continue the same dose. Or maybe it's the drug, it's not really effective. Now we do understand that allopurinol, there is a polymorphism that actually controls the delivery of allopurinol inside the cell. And maybe some people are going to respond less and some people are going to respond better. So it maybe could be all of these factors altogether. I just want to show you that we actually have an evidence that in this trial where it actually was run in the UK. So basically they have 517 patients uncontrolled gout. They put them in two groups, they randomized them in two groups. The first group is a treat to target. They are a nurse-led practitioner, so they are trained how to treat gout, and they're nurses. And the other group was physician, general practitioners. So they followed these patients for 2 years with an intention to treat analysis. Very interesting results for me. So if you go through and see and compare, so the one on the left are the nurse-led and the other one is the general practitioner, you can find that 95%, I repeat, 95% on the second year, the nurse-led group, they reached to a serum urate less than 6. However, if you go to the doctor's group, that was only 30%. The results actually replicate itself. The number of flares, 8%. More than 2 flares per 2 years, and 25% in the physician group. The mean dose of the allopurinol, you can find that it's 460 milligram in the nurse-led group, while it was only 230, TOFI existence. I think what we can get from this study is, obviously nursing are good, but if you have a target, it's an achievable and attainable, and we can reach it if you make yourself go through it. So I think this is an important thing, is that maybe we don't have to have new medications. Maybe we need to know how to use our pre-existing medications. Just wanted to bring your attention to a concept in gout, which is the time concept. So it takes time to accumulate uric acid to deposit. So not everyone deposits the same. A very excellent example here is the tumor lysis syndrome. This day the patient has uric acid of a normal result. The second day they might have it over 16 or 18 milligram per deciliter. They don't have gout because it takes time for you to deposit these crystals in order in the future to have gout. As long as you're having time to dissolve, to form the crystal, also you have time to dissolve it. So you have to have some patience. And the most important thing is basically it takes time for gout flares to stop. So if you're starting treatment, and the patient keep having attacks, please remember, it's not a failure of your treatment. It's the time concept. You have to give it some time in order for you to dissolve and control this thing. Okay, so a couple of words on febuxostat. So febuxostat in real clinical practice, we kind of consider it as second-line urate-lowering therapy. It's actually appropriately used if you fail or intolerable to allopurinol. It has a distinct chemical structure, so those patients who has allopurinol hypersensitivity, we can use them as cells. There are a couple of reported allergic reactions, but you can use it. It's more expensive than allopurinol. Allopurinol box costs you about 10 to 15 reals. The febuxostat, it's about 110 reals. The other problem with the febuxostat is the dosing, because we have the 40 milligram pill, maybe the 80, and that's it. So you can't really titrate it up. And the problem is that the 40 milligram febuxostat is actually equivalent to 300 milligram of allopurinol. So if you started from the beginning, you're going to plumb the serum urate level, and then that might induce an attack. All the big talk about the black box warning, about increasing cardiovascular risks, but the future actually, or the subsequent analysis did not really show big difference between febuxostat and allopurinol. And people are becoming more adaptive of the use of febuxostat and not really be really scared of this cardiovascular risk factor. Uricosuric therapy, it's an old medication that's been revived in a way. This study actually from 1959 did show it has some efficacy. What they are suggesting in the newer trial that you can use it as an add-on. So you add it on to the allopurinol to get the best results. It does have GI upset. It does have some rashes. The renal stone is not a big issue as we used to think, unless if the patient has nephrolithiasis from the get-go. Pegloticase. Okay, so pegloticase, as you remember, all the mammals, they do have the uricase, and then that's why they don't get gout, except us and few other mammals, including the Dalmatian dogs. We don't have uricase, and then that's why we get gout. So basically, it's a recombinant mammalian uricase. The pegloticase is a recombinant mammalian uricase that is attached to PEG. To polyethylene glycol. Now, the FDA statement is that we use it for treatment of chronic symptomatic gout that are not responding to maximum doses. They did not really specify what maximum of xanthine oxidase. This is the FDA label. Just a quick poll here. Any one of you have used in Saudi Arabia pegloticase? Those who does, just please raise your hands. And I guess the reason is it's not yet Saudi FDA approved, and it's actually $32,000 per vial. So this vial is actually costing $32,000. But I guess mainly because we don't have the Saudi FDA approval, yes. So the trial, it was, you have this expensive drug, we have this refractory disease, it should do this, right? So most of the patients who are in red who take the pegloticase after the first dose, it's like a magic, they plumb down, and then we think that we finally solved the problem. Well, it's not completely correct, because it actually, up to 56% of people, they actually did not respond, or the uric acid started to raise up again. So that was a disappointment. So then obviously the studies goes through, and then we find that there is an immunogenicity with pegloticase, and then there was so many efforts trying to overcome this immunogenicity. So they started first with the high zone tolerance, which basically they increases the dose to oversaturate the antibodies, but that didn't work. So then they tried to use other immune modulators like the MMF, mycophenolate, like the azathioprine, leflunomide, in case reports with some successes, till they actually, and this was actually presented in the poster in ECR of 2018 of series of patients that they use methotrexate. So they bring this fact and then they put it in a randomized double-blinded trial where they actually, which is called the mirror trial. So what they've done here is that they bring the patient population there. These are the patients who had hyperuricemia, chronic gout, not responding to xanthine oxidase inhibitor, and they have the symptoms. So they were not really strict about what was the dosing that you have to use, but these are the patient population. They should have gout that's not controlled or tophaceous gout. So what they did, they brought the patients at the pre-study period. They used methotrexate to test the tolerability, and then after they did that, they randomized the patients into two groups. One group, they used the methotrexate, and the other group, they used placebo instead of methotrexate. And this is the patient disposition. So you find the one on the purple are the one who use the methotrexate. About more than 70% they continue till the end of the study. While if you go to the other side, the ones on placebo, there was actually only about 30% or 40% that they completed the study. The main reason for discontinuation is drug inefficacy. That was the main reason. And this is the primary endpoint. They did meet it nicely. Patients who are taking methotrexate, they have significantly better response than those who did not take the methotrexate. And if you go through the adverse events arms, they actually did very well. Patients who took the methotrexate, they had less infusion reaction. The minor side effects were comparable between both groups, and it worked fantastically. It doesn't make sense to treat patients with gout with methotrexate in order to make the pegloticase work, but it did work without the major side effects. However, just to remind you, most of these patients, more than 70% of these patients, they develop acute gout flare. So, about time. Going back to take-home messages. Now, hyperuricemia, we show you that it's necessary, but they are not sufficient. There are some other factors that we don't fully understand yet. There are other factors about the crystals themselves, about the host, which is the synovial host, that we still need to know and understand. Remember that difficult to control gout does not mean by any means that it's a resistant disease. We need to know how to use our medications better and better to control the disease. Allopurinol continues to be the first line, and it's not nephrotoxic. Appropriate urate lowering therapy does remove the deposits over time. So you have to give it some time. It's not something that happens very quick. You have to give it some time. You have to educate your patient that it takes some time. And treatment to target is something that is achievable in gout. I'm done. Thank you.